Welcome everyone to the EKG case of the week for June 24th, 2012. This week's case, initial case at least, was provided by Dr. Scott Williams, who's an attending physician at York Memorial Hospital in York, Pennsylvania. I ran into him at a board review course, and he had this EKG to present. He's a 51-year-old man that he and his colleagues took care of, who presented with severe shortness of breath. And what they noticed on this EKG was a bunch of T-wave inversions, which at first glance would make you think that this patient's shortness of breath is due to diffuse cardiac ischemia. However, they knew a little bit more, and what they were able to diagnose based on this EKG, the presence of T-wave inversions in the anteroseptal plus the inferior leads together. Turns out, as we've talked about before, that EKG abnormality is very highly specific for pulmonary embolism. That's what this patient ended up having. T-wave inversions in the inferior plus anteroseptal leads together. When they occur simultaneously, that's highly specific for pulmonary embolism. This was something that was first described by Marriott a number of years ago, and it's been published in other literature. It's starting to make its way into emergency medicine articles as well. And we actually talked about this on the video casts back in December, but there's a few cases that have come across my desk, including Dr. Williams' case, that made me want to just go over this once again. So what you see on this slide, this is the classic thing that we've all learned about pulmonary embolism. We've all learned, unfortunately, that pulmonary embolism produces sinus tachycardia. And when I poll audiences, oftentimes people will say, on the order of 70 or 80% of PE cases produce sinus tachycardia, and that, unfortunately, is a myth. It turns out that in the biggest international studies that have been done on EKG abnormalities of pulmonary embolism, only 30 to 50% of patients with proven PE will produce a sinus tachycardia. So the majority of these patients are actually not tachycardic. In fact, the patient that Dr. Williams presented was actually running a heart rate in the 90s, so not quite tachycardic, but nevertheless, that's something that continues to get drummed into the heads of medical students and residents around the country and probably around the world also. Bottom line here, don't rely on tachycardia, even though it's classic. Most of us have probably learned about this classic S1 Q3 T3 finding, right? A big S wave in lead 1, Q wave in lead 3, and a flip T wave in lead 3 as well. Or sometimes maybe there's just an S1 and a Q3. Bottom line, if there's a big S wave in lead 1, it's a rightward axis, and that's classic, and classic in medicine, as you know, means not that common. Probably about 15% of patients with a proven PE will have that S1 Q3 T3, and a lot of patients that are normal and asymptomatic and don't have PEs will have an S1 Q3 T3. That means that finding, although classic and always being taught, is neither sensitive nor specific. But anyway, it always shows up on the boards, so it's something worth knowing about. And then another finding for right heart strain is a new right bundle or an incomplete right bundle branch block pattern, or simply what you'd look at and see a tall R wave or R prime wave in lead V1. That's a sign of right heart strain. Well, there's a few other things that you should look for in PE cases as well. We know PEs can produce atrial dysrhythmias, SVT, atrial flutter, atrial fibrillation can be produced by pulmonary embolism. You can even have runs of ventricular tachycardia from pulmonary embolism. That's probably not a big surprise to people out there. Here are a couple things that for people that haven't been keeping up with the EKG literature or the EKG videocast, you may not know about this, that PEs can produce ST elevation or ST depression, not necessarily that commonly, but it can mimic a STEMI or a non-STEMI. And the other way that PE can mimic non-STEMI is with T-wave inversions in the inferior and anteroseptal leads. And this is what I actually want to talk about in this brief segment, because flipped T-waves, I think we've all learned flipped T-waves equal cardiac ischemia, and it's very rare for people out there to teach that flipped T-waves are actually not specific for cardiac ischemia. Flipped T-waves, in fact, are very common in cases of large PEs. And when you look at the EKG literature, which just looks at large pulmonary emboli, what you find is that new T-wave inversions may very well be as common, if not more common, than sinus tachycardia. Again, in cases of large PEs, flipped T-waves are fairly common. Maybe as many as 50% of patients with large PEs will show up with a new T-wave inversion or new T-wave inversions in an anatomic area that make you think that they're having ischemia. And Marriott talked about this several decades ago. When you see the combination of T-wave inversions in the anteroseptal plus the inferior leads, that should be thought of as pulmonary hypertension. And in emergency medicine, pulmonary hypertension, especially if it's new pulmonary hypertension, new flipped T-waves in the inferior anteroseptal leads, is PE until proven otherwise. And that's what showed up in Dr. Williams' case. Let me show you another case. This was given to me by someone within our system just probably about a month after Dr. Williams gave me his case. There's another patient, 49-year-old woman, that presented with chest pain and shortness of breath. Notice the heart rate is in the 70s. This patient is not tachycardic. Chest pain, shortness of breath. This patient had borderline instability. This was a fairly large PE, and you'll notice that there's flipped T waves in the inferior and the anteroseptal leads. And people who don't know about this EKG literature would be inclined to say this is cardiac ischemia, and it's not cardiac ischemia. This is actually a big PE. And here's one more case just to really hammer this home. This was given to me by one of our residents, Dr. Zach Desmond, who also collects EKGs and gives me a lot of great cases. This patient has a sign of right heart strain. In fact, it has a full-blown right bundle branch block pattern. There's that big RSR prime in lead V1. You'll also notice that there's a little bit of ST depression in this case. Now, it's normal to have ST depression in right bundle branch blocks in V1, V2, V3, but what's abnormal, there really shouldn't be ST depression in other leads in a right bundle branch block. There's ST depression in those leads there. And what also you should not normally see, you can see some T-wave inversions V1, V2, maybe V3 in our normal right bundle, but these T-wave inversions in V2 and V3 are a little bit more than you'd expect. And also, you see T-wave inversions in all of those inferior leads, and that's not normal with the right bundle. Right bundles, by the way, can sometimes produce T-wave inversion in lead 3, but really shouldn't produce the T-wave inversions in all of your inferior leads. And so the concern here, is this just a plain old right bundle branch block, or is there something else going on? Well, it's not a plain old right bundle branch block pattern, because there's a little ST depression. There's also T-wave inversions in all of your inferior leads. There's a little bit more T-wave inversion in V2 and V3 than you normally expect. And so you might be inclined to read this as, hey, this person's got a right bundle, but they also have inferior and anteroseptal ischemia. Well, remember what Marriott said. Whenever you see T-wave inversions in the inferior and anteroseptal leads together, that's a PE until proven otherwise. If you ever read an EKG as infero-anteroseptal ischemia, stop and think, is this a pulmonary embolism? And sure enough, that's what this patient ended up having. This patient had a large PE and was hemodynamically unstable. So just 3 more cases to build on top of the video cast that we did back in December 2011, which talked about T-wave inversions in PE. Here's another 3 more cases demonstrating this is not an uncommon finding. Large PEs will produce T-wave inversions that mimic inferior and anteroseptal ischemia. So, simple bottom line. Anytime you read an EKG as inferior and anteroseptal ischemia because of flipped T-waves in those leads, that patient has acute pulmonary hypertension, if those are new findings. And in emergency medicine, acute pulmonary hypertension, new pulmonary hypertension equals pulmonary embolism until proven otherwise, and chances are it's a big one. So, hope that was helpful, and I look forward to talking to everybody next week with another great EKG case of the week. Thank you, and bye for now.
This is a video in clinical medicine from the New England Journal of Medicine.
This video will demonstrate safe and successful methods of performing lumbar puncture. Lumbar puncture is indicated for both diagnostic and therapeutic purposes. Also, the administration of spinal and epidural anesthesia involves the use, essentially, of this same technique. Analysis of cerebrospinal fluid may be helpful in the diagnosis of infectious processes such as meningitis, inflammatory diseases such as multiple sclerosis, cancers such as leukemia, and metabolic processes. Therapeutically, lumbar puncture allows for the intrathecal administration of chemotherapeutic agents and antibiotics. There are specific contraindications to lumbar puncture. The condition of patients with cardiorespiratory compromise may worsen as a consequence of the position they need to assume for lumbar puncture. The procedure should also be avoided in patients with signs of cerebral herniation, incipient herniation, or increased intracranial pressure, and in those with focal neurologic signs. In such patients, cranial CT should be performed before lumbar puncture, although CT may not reveal signs of increased intracranial pressure. Finally, there is an increased risk of a spinal hematoma if a coagulopathy is present or if the patient is receiving anticoagulant therapy. Patients who have previously undergone lumbar surgery should be referred to an interventional radiologist. Before performing the lumbar puncture, you will need a commercially available tray containing the necessary supplies, a spinal needle with a stylet, equipment for skin preparation, drapes, collection tubes, and in some cases a manometer. Typically, a 20 to 22 gauge needle is used, with the length ranging from 1.5 inches or 3.8 centimeters for infants to 2.5 inches or 6.3 centimeters for children and 3.5 inches or 8.9 centimeters for adults. You will also need sterile gloves. Before you begin, you should explain the procedure along with potential risks and benefits to the patient and obtain informed consent from the patient or his or her parent or guardian. After obtaining appropriate patient consent, the patient is positioned. Either the lateral recumbent position or a sitting position can be used. The lateral recumbent position is preferred to obtain an accurate opening pressure and to reduce the risk of post-puncture headache. Instruct the patient to assume a fetal position or to arch like a cat with the back flexed. This position widens the gap between the spinous processes. Ideally, the lumbar spine should be perpendicular to the table if the patient is in the sitting position and parallel to the table if he or she is in the lateral recumbent position. These positions help keep the needle at the midline. A line is visually drawn between the superior aspects of the iliac crest and intersects the midline at the L4 spinous process. Insert the needle in the interspace between L3 and L4 or L4 and L5, since this location is below the termination of the spinal cord. Palpate the landmarks before preparing the skin and before administering local anesthesia, since the anesthesia may make landmarks harder to identify. Use a skin marking pin to identify the site of needle insertion. While wearing sterile gloves, clean a sufficiently large area of the overlying skin with a disinfecting agent such as chlorhexidine or providone iodine using a pattern of widening concentric circles. Drape the area with sterile drapes. Lay out the collection bottles in the order of priority for the diagnostic indications. Lumbar puncture is a painful and potentially anxiety-provoking procedure. At a minimum, the use of a local anesthetic is appropriate. Sedation or systemic anesthesia may be required under some circumstances. You can apply anesthetic cream topically before preparing the skin. After preparing the skin, you can inject local anesthetics subcutaneously. Identify the anatomical landmarks once again, and insert the needle, with stylet firmly in place, in the midline at the superior aspect of the inferior spinous process, directing it at an angle of approximately 15 degrees, as if aiming at the patient's umbilicus. Either use a pencil-tipped needle or assure that the bevel of the needle is in the sagittal plane so as to spread rather than cut the fibers of the dural sac. These fibers run parallel to the spinal axis. The use of this needle position should theoretically decrease the leakage of cerebrospinal fluid. If properly positioned, the needle should pass through the skin, the subcutaneous tissue, the supraspinous ligament, the interspinous ligament between the spinous processes, the ligamentum flavum, the epidural space, including the internal vertebral venous plexus, the dura, the arachnoid, into the subarachnoid space, and between the nerve roots of the cauda equina. As the needle passes through the ligamentum flavum, you may feel a popping sensation. Once you have reached this point, the needle should be advanced in 2 mm increments and the stylet withdrawn after each increment to check for CSF flow. If no fluid is detected and bone is encountered, withdraw the needle to the level of subcutaneous tissue without exiting the skin and redirect the needle. Fluid will flow once the needle enters the subarachnoid space. If the lumbar puncture is traumatic, the cerebrospinal fluid may be tinged with blood. As additional fluid accumulates in the barrel, the fluid should become clear, unless the source of the blood is a subarachnoid hemorrhage. If the flow is poor, a nerve root may be obstructing the opening of the needle, and you should rotate the needle 90 degrees. If drops of blood enter the needle, it may become clogged. In this case, you should obtain a new needle and enter the site through a different interspace. For you to obtain an opening cerebrospinal pressure, the patient must be in the lateral recumbent position. Use a flexible connector and attach a manometer to the hub of the spinal needle. After waiting for the column of fluid to rise and possibly seeing pulsation from cardiac or respiratory motion, you may take a measurement. If the cerebral spinal fluid pressure exceeds 25 centimeters of water, you should closely monitor the patient for signs of herniation and determine the cause of the patient's elevated intracranial pressure. You must allow cerebrospinal fluid to drip into the collection tubes. Never aspirate cerebrospinal fluid. Even a small amount of negative pressure can precipitate a hemorrhage. The amount of fluid collected should be limited to the smallest volume necessary for testing. Typically, 3 to 4 milliliters of fluid is sufficient for routine indications. By turning the stopcock toward the patient, fluid in the manometer may be collected. After collecting an adequate specimen, replace the stylet and remove the needle. Although traditionally patients have been told to lie flat for several hours after a lumbar puncture, there is no evidence that this precaution decreases the risk of a cerebrospinal fluid leak, post-puncture headache, or other complications. All sharps should be properly disposed of in appropriate sharps containers or needle lock devices to help minimize the risk of needle stick injury. Obese patients may represent a challenge due to difficulty in identifying landmarks. Other conditions, such as osteoarthritis, ankylosing spondylitis, kyphoscoliosis, Previous surgery that has altered landmarks or spaces, and degenerative disc disease also may make the procedure more difficult. If faced with these challenges, consider consultation with an anesthesiologist or perhaps a radiologist if fluoroscopy-guided lumbar puncture seems to be a better approach. Lumbar puncture has numerous possible complications, including cerebellar herniation, referred pain, headache, bleeding, infection, the formation of a subarachnoid epidermal cyst, and leakage of spinal fluid. You can avoid many of these complications by conducting a careful assessment of the patient before the procedure, including a thorough neurologic examination and retinoscopy, and monitoring the patient throughout the procedure. A subarachnoid epidermal cyst occurs when a skin plug is introduced into the subarachnoid space. The standard use of a needle with a stylet will avoid this complication. Leakage of spinal fluid can occur at the puncture site. A large bore spinal needle is more likely than a smaller bore needle to produce a leak, so the latter should be used whenever possible. In the case of persistent leakage of spinal fluid, an anesthesiologist should be consulted to determine whether a blood patch is needed to occlude the leak. Lumbar puncture is a commonly performed procedure that can be a very useful aid in clinical diagnosis and treatment.